Hello and welcome to our interview with Dr. Grant Rodney on the topic of Behind the Mask. Dr. Rodney works as an anesthesiologist at the Nine Wells Hospital in Dundee in Scotland for more than 20 years. I heard it's like almost 30 years, but he can maybe introduce himself afterwards. So, as an expert in this field, Dr. Rodney has an extensive knowledge of the use and benefit of the objective neuromuscular blockade monitoring and anesthesia, and we are very excited to learn from his experience today. We will be discussing the important topic on the neuromuscular blockade monitoring and gaining insights from Dr. Rodney's daily case experience. So thank you very much, Dr. Rodney, for joining us today. I take off my mask. And you are involved with device evaluations, trainings, education, seminars, webinars, this interview. So can I say that you have a particular passion of neuromuscular monitoring in enhancing clinical practice?
So I'm not sure why, but I've always had an interest. I've always been a twitcher. I started out using standard peripheral nerve stimulators to assess the quality of recovery of my patients, and then moved as we moved towards more availability of quantitative neuromuscular monitoring devices. So just by way of information, I'm not an academic. I'm a working clinician. I have a mixed adult and children's practice. I'm very interested in developing world anesthesia as well, and I've worked and taught abroad. And so my interest led me to being involved in the Association of Anaesthetists Standards of Monitoring Group. So since about back in the late 1980s, almost on a 5-year cycle, there are updates to the standards of monitoring from the association, now up to the version number 6, I think it is. So I was involved back in 2015 in being part of that working party that established those guidelines, and then back and also just in 2021, so been involved in those and had the particular role of collating information and agreeing with my colleagues what we should propose around neuromuscular monitoring. And back in 2015 was the first time the Association of Anaesthetists actually formally came out and said that neuromuscular monitoring should be used for all patients receiving paralytic drugs through all phases. And at that point, we encouraged, if you like, or recommended for departments to move to this type of monitoring. The most recent update of that has moved on further and quite clearly stated amongst the key recommendations with some backup evidence and key publications is that should be always quantitative neuromuscular monitoring throughout all phases of anesthesia. So I think just in broad terms, Stephanie, what I think is really interesting is where we're at. It's a journey of many decades, and we've not fixed this problem. And still, the literature evidence is that 30%, maybe even 40% mean in terms of studies, patients experience residual neuromuscular block. And that's despite the move to the intermediate duration drugs, atracurium, vecuronium, and so on in the 1990s, to many publications and editorial calls to quantitative monitor into the early 2000s, to the introduction of sugammadex, a new antagonism agent for, as you know, for the immunosteroid vecuronium and rocuronium drugs. And so here in 2023, why I think it's such an exciting and challenging time to keep fighting the battle, as it were, because I don't think we've fixed this problem. And so what's fascinating is that in addition, just hot off the press earlier this year, both the ASA, the American Society of Anesthesiologists, and ESAIC, the European Society, with expert groups dissecting the evidence independently of each other, have come up with recommendations which are essentially broadly completely matched and in agreement, and it's reassuring in a way that independently that's happened, and the evidence evaluation, and really the headline from that is that quantitative neuromuscular monitoring should be used, because the absence of that, we cannot have any certainty. We will be guessing where we're at in terms of recovery. The presence of fade of the fourth to first twitch in a trainer 4 sequence on a qualitative standard device, which can't measure for you the trainer 4 ratio, will always leave us with a gap of uncertainty. The recovery level when there is no fade can be anywhere between 0.4 or 40% and 1 or unity or 100%. So this is fascinating that the conclusion of both of these bodies has come up with that. And at the same time, interesting observations and recommendations around the choice of neuromuscular block reversal, which essentially is a sugammadex neostigmine 1. Of course, sugammadex only applicable and to the vecuronium, rocuronium group and not to benzyl-isoquinolinums, which can't be reversed with that and require neostigmine. So I think, and as I said, both gave dosage guidance and recommend caution with use of neostigmine till high levels of recovery. Essentially, trainer 4 ratios above 0.4, so-called minimal neuromuscular block, where neostigmine can provide pretty much equally speedy and effective reversal as sugammadex. Once you're deeper than that, they recommend, and I would agree with this from my clinical practice, get as high a recovery as you can before neostigmine reversal. Always, you have to have a quantitative neuromuscular monitor when you're using that drug, or sugammadex indeed, and give the drug early in the correct dose and give enough time for it to work. So that's fascinating. And then I think another reason why I think 2023 is so important is the interplay between monitoring the drugs we give, the types of surgery we do, and then the reversal of those drugs. And so I think the great challenge for the anesthesia community will be that challenge of a perception that if we have this drug sugammadex, that we no longer require neuromuscular monitoring. And I would strongly refute that, because monitoring is required for all phases, to determine the variability in onset of drugs, to determine the need for top-up doses during maintenance, and then to know where you're starting from before you reverse, because the dosage guidelines for reversal are quite clear. So if we're not measuring where we're at the start, what dose of drug are we going to give? And then why not have the certainty at the end that the trainer 4 ratios reached that recovery level of a minimum of 0.9, and some would suggest higher for acceleromatography. We know that from the popular study with rework data, which showed that at 0.95, but not at 0.9, the incidence of postoperative pulmonary complications was reduced. So I think there's a great opportunity, there's a great challenge for our community to embrace the fact that what we need for our patients who are becoming increasingly more complex, more elderly, more frail, levels of obesity. And in these patients, it really matters in terms of quality of outcome, reducing postoperative complications, reducing length of stay, reducing the risk of awareness, reducing hospital stay. And in not so doing, we're obviously adding on problems for those patients, as well as significant costs as well, because there's always a cost argument, is there, around the cost of the monitors, the cost of the drugs. But we don't see that endpoint, that prolonged hospital stay or that need for a critical care bed, unless we look for it. So I think we, as I said in summary and in closing on this particular one, I think it's a fascinating year, and I think it's a great opportunity. I think we need to keep lobbying for our patients. And in my view, it's about thinking about the anesthesia technique in collaboration with the types of surgery, making a plan and having a strategy, which needs to vary because things change during clinical conditions. Surgery changes, becomes longer, shorter, easier. but having the flexibility to deal with that by using appropriate monitoring and then the appropriate drug to reverse a patient, and then the certainty, and the incidence of residual paralysis should be one that we should be able to essentially set ourselves a target to eliminate in its entirety, and we cannot do that unless we monitor with a quantitative neuromuscular monitor, whatever the technology is, AMG, EMG, etc. Thank you. I don't know, but we have to set ourselves challenges and targets, and I applaud that. And I think there's just one small point I'd like to add, which is that we're talking in the Western world, and we have financial issues accessing equipment and monitoring and drugs, but we have to remember that the global population isn't even in a position to have these arguments, can't measure and doesn't have access to those drugs. So you don't know till you try, but I think it's an absolutely laudable aim to target, and it's a work on, and it will continue to be so.